We'll invite again Dr. Huang to share with us whether the freeze-all is a strategy for all patients. Dr. Huang, please.
Thank you for staying until now. I hope you have a lovely tea. So again, I'm tasked to give a very interesting topic. Can we move on to the slides, please? Yeah, which is talking about using freeze-all as a strategy. Excuse me, using the slides? Yeah. Okay. So today the topics that we're covering will be, I will always start with the definition. What do we understand by a freeze-all strategy and why are we doing this? And importantly, I want to compare, I guess everyone here who is seeing patients want to compare the outcomes of your fresh embryo transfer versus your frozen embryo transfer. And truly, who does better with freeze-all? And some of the concluding remarks we can get from the current evidence that's being published. And I think one important thing is that just now, I think Dr. Andrew Khan has actually mentioned and emphasized quite a lot is that you have to ensure that the laboratory, the IVF laboratory that you're working with, does an excellent job of freezing the embryos and thawing the embryos with high survival rates. So there are some labs that they are still new and may have problems with getting thawed embryos that survive. So, if there are any of some concerns, then obviously that first thing is that you shouldn't freeze-all strategy shouldn't be the case. So this, I will give a misnomer that disclaimer that all the freeze-all strategy should be in an IVF lab where the IVF lab is very, very experienced in doing freeze-thaw cycles, okay, with high embryo survival rate. So we'll start with some common questions again to see how everyone thinks about this. So the first thing is, what is the main reason when we talk about a freeze-all strategy? Why do we want to do a freeze-all strategy? So what do you think is the main reason? No response yet? Okay, try one more time. Everybody just got back. Okay, what is the main reason for a freeze-all strategy? Okay, wow. Okay, so I think everybody seems to know the true and main reason for this strategy. Okay, and that's correct. All right, and then the next question. So after an ovarian stimulation, what do you think happens to the endometrium? Let me give you a little bit more time to read and understand. So what do you think happens to the endometrium? Okay. Oh. All right. Wow. Not too bad. Oops. Right. So yes, most of you are actually understanding correct because all seems to know that the endometrium seems to reach receptivity phase a bit sooner than expected after ovarian stimulation. So coming to the most important thing, the definition, and I think that most of you really know what the aim of a freeze-all strategy is. And essentially what we do in freeze-all strategy means to freeze the entire embryo cohort, okay, to achieve a deferred embryo transfer. So you do not even have embryos that's being frozen because it's supernumerary. Okay, that means all the entire cohort, whatever embryos you have, you just all defer to the next cycle. Okay, and this process of embryo transfer, which what Prof. Yu was mentioning about, you actually restart another cycle to get the endometrium ready, and it's definitely separate from the process of another ovarian stimulation and oocyte retrieval. So why do we freeze all? Now, I think the major difference is that you time when the embryo transfer happens in relation to ovarian stimulation. So there are enough studies to show us that actually after the ovarian stimulation, there's very high or supraphysiological concentrations of estradiol and progesterone that are usually reached. And because of this, okay, the other word that we need to talk about is endometrium receptivity. All right. So receptivity also means that it is the time when endometrium in all its, biomolecules, milieu and everything is ready to accept and allow an embryo to implant, subsequently invade, resulting in implantation, and then going to the endometrium, finally forming a pregnancy and releasing beta-HCG. Right, so this is the one that is important. And as of now, I'm sure the other expert audience amongst us know that endometrial receptivity is still something in the talking, and we are still trying to find when is the ideal window of implantation. But we do know there's evidence that shows that after ovarian stimulation, the endometrium is able to reach its receptive phases much earlier, which many of you seems to understand that as well. And it's as early as 2 to 4 days. Okay, and this is really based on a large number of endometrial biopsies carried on the day of oocyte retrieval compared to biopsies carried in natural cycles. So these are all from very, very early studies, but it's something that's quite interesting that we are able to sort of see that. And the freeze-all policy, primarily, if you want to do that, is really trying to achieve a more physiological condition, such that your embryo that you put back is facing a more, natural environment that we think it is before. And I have to include this reference, which is one of the later ones in 2022. And essentially, we have to talk about all these little biomolecular mechanisms that I hope all of you can understand. Because these are the mechanisms that we're thinking about that regulate the optimal window of implantation. So this optimal implantation means basically that the endometrium lining here, whatever molecules that's happening all the way from a synchrony between your endometrial cells coming together, working with your lymphocytes and your immune system, and the various cells coming together, getting ready for implantation, all right? And to make sure that the blastocysts and the lining are all in sync, allowing actually proper signaling between all your endocrine markers, your estrogens, your progesterone, all the receptors are all ready to do what they do. And importantly, we do know that to achieve a pregnancy, the immune system must be ready and slightly more tolerant, okay? Because you're going to put an embryo that's not entirely cells into a woman's endometrium, okay? And the other important genetic variations that come about is cell adhesions. You talk about the embryo sticking on, implanting, invading, angiogenesis, where the blood vessels need to come and supply and grow the pregnancy. And a lot of time, what we do in recurrent pregnancy loss test, we check about risk of clotting and all these things. So all these things has to come in place, and they must all be ideal and in sync to ensure a proper implantation. So do we know all these steps? Do we have a test to diagnose all these steps? And I think the answer is still out there. We are still looking at it, and I don't think we have all the answers to this. And one of the things that when I was looking at this topic again, and I feel that we're always looking at live birth rates, right? As what the other speakers are alluding to, birth rates is really at the end, of what we're doing from the beginning, trying to get an embryo from ovarian stimulation, and then getting embryo and seeing the outcome of that process. Whereas discounting the, about implantation rate, clinical pregnancy rates as well. And what is interesting to note that most of this study, and we have looked through many, many meta-analyses today, and looking at many forest plots. And what is shown is doing fresh and elective embryo transfer in all cycles. Okay, this is a recent publication, Reproductive Update itself. You notice that everything is at 1, right? So everything that crosses 1, it just means that it doesn't favor either. So the answer seems to be very straightforward, that if you do a fresh or frozen cycle, perhaps, there's no inclination to either. But is it the truth, or is it something we're missing out? So when you look at this, okay, if we do a freeze-all strategy versus a fresh blastocyst transfer strategy during in vivo fertilization in women with regular menstrual cycles. Okay, so this is something that's quite interesting because we know about high responders. And high responders to us tend to be women with a lot of ovarian follicles and tend to be women with PCOS, right? And they tend to have irregular cycles, okay, very high ovarian reserves. So this article is published in BMJ, I believe. Yeah. Interesting is that we know, have increasing pregnancy rates, which what we observe after frozen thaw embryo transfer, seems to encourage a freeze-all strategy, okay, in ART. And a freeze-all strategy that uses GnRH agonists, okay, will minimize the risk of ovarian stimulation, hyperstimulation syndrome. But this again is only in high responders, okay? But what about a freeze-all strategy, right? With agonist triggering, okay, using HCG. All right, they also compare this. Okay, but what is new? What is new about this particular study is that even with regular cycles, okay, just freeze-all strategy with an gonadotropin releasing hormone agonist trigger does not result in higher ongoing pregnancy and life birth rate than a fresh transfer strategy with HCG gonadotropic triggering. So note that what they're trying to say is that in this case where we use a HCG trigger, and we need to, and all of us who are practicing IVF know that for long protocols with the agonist cycle, we know that we need to do HCG triggering, and that's why OHSS risk is high. But in this case, if we're using just an antagonist protocol and using GnRH agonist, which is only for high responders, okay, women with regular cycles do not seem to have an increased, life birth rates or ongoing pregnancy rates. All right. So what they suggest here based on their study is that a safe fresh embryo transfer can be applied to women with regular menstrual cycles. Okay, and strict cancellation if an excess number of mature follicles are present. Right, because we're all worried about the high responder in this case. So high responders, regular cycles, maybe just be careful. But what they're trying to say is that means that there's no obvious difference. And if you want to look at the numbers of patients they actually compare between freeze-all group and fresh embryo transfer, I think it's not huge numbers, but it's enough for us to note the difference in this particular new study. And I think it's quite interesting when we are trying to look at who should be the candidate for freeze-all strategy, and this is for every woman. And this is a nice summary, which I also get from another recent publication, Human Production Update, really to look at, what are the outcomes of mothers and babies, because there have been some studies that shows that, perhaps, this is better, that's safer, and the mothers have lesser chance of preeclampsia, smaller gestational age for babies. So we have evidence for many, many years, and then this very nice summary seems to suggest from cumulative meta-analysis, what should be done more to find out the real answers and what actually is already known between fresh and frozen cycle. So small for gestation age, we know there is lower risk in frozen embryo cycle. Okay, we don't need to prove that. And because it is small for gestation age, we have low birth weight and very low birth weight. So we don't need additional data. And we also note that in higher frozen embryo transfer, large for gestation age, high birth weight, and very high birth weight. This is again higher in frozen embryo transfer. Okay, so we don't need to check on that anymore. How about preterm delivery and very preterm delivery? Now, this is something that, again, we notice that it's probably a bit higher risk in fresh embryo transfer. All right, and that could actually explain why you have low birth weight and very low birth weight from preterm deliveries. So again, this is still quite common sense. And how about the other concerns? Antepartum hemorrhage, admission to NICU, NICU, congenital anomalies, perinatal mortality, and interestingly, hypertensive disorders of pregnancy, which a lot of studies have actually shown there is high frozen embryo cycle and frozen embryo transfer, primarily because they have studied and showed that the corpus luteum, okay, in a natural thaw cycle, the natural corpus luteum by itself actually releases a lot of androgenic factors that relaxes the body and keep the androgenic tone good. And there were from quite a number of key studies from certain, I think, not sure is it, from the European groups that actually showed that the corpus luteum actually produces relaxin and actually results in lower risk of preeclampsia and hypertensive disorders in pregnancy. But then again, that's only in natural cycles. So if you have more than one corpus luteum in a fresh cycle, okay, that's a different story altogether because those are not natural corpus luteum. Okay, those are multifollicular, multi-corpus luteal that are deficient because of the cycle they're going through during egg pickup. Okay, so this is something that is interesting. And with this argument in place, it's still very divided. Should we use a freeze-all, for everybody? Is it something that we should use for everyone, knowing that the outcomes again now differ? Because we need to talk about to patients eventually, you may have higher risk of small for gestation age baby. We need to induce you earlier. You may have preterm delivery, or baby get very big. We need to do a selective cesarean section because we have other complications. So things like that we still have to take into consideration when we look after our patients. Now, this is another study that I think is quite important, and I find it very interesting because as IVF doctors, we all think about ovarian response when we do the IVF cycle. And thus, ovarian response itself actually matters the most in deciding when you do a freeze-all strategy. Okay, so again, they're showing now a lot of studies are showing cumulative live birth rate. All right, so I can only share with you cumulative live birth rates at this point in time for a freeze-all strategy. And this is a population-based study. And what I felt is very interesting was that, overall, it's looking at the number, okay, of oocytes that are being retrieved, okay, and they're showing. You see what you call this brown line. Okay, there's a fresh transfer, and the dotted blue line is a freeze-all cycle, and they're looking at the cumulative live birth rate based on the number of oocytes. So if you see cumulatively, if you have more cycles, obviously your cumulative live rate goes up. And it seems that freeze-all at this point, if you put everyone together, seems to have higher chances of pregnancy as they go on. But if you start to divide them into number of oocytes retrieved, so those with less than 10, okay, you have seen that actually a fresh embryo transfer seems to offer a higher cumulative live birth rate as the number of cycles goes up. And your frozen freeze-all cycles seem to do much poorly, and you can see this gap is quite significant. And how about if you have your normal responders, say the ideal one that we want to have, within 10 to 15 oocytes retrieved, you also continue to see a difference between the cumulative live birth rate. Okay, so you see this brown line is still higher, okay, for fresh transfer in women with good normal response. And yet, if you do a freeze-all strategy for these women, the cumulative birth rate does not seem to be much better. How about women with lots of oocytes, the very high responders you talk about? And then you see, actually, for freeze-all cycle, and they don't see a huge difference, but there could be still some benefits because with so many oocytes retrieved, most of us will err on the side of caution and will do a freeze-all anyway, because you want to avoid OHSS. And I think this paper has been shown before as well. So fresh versus frozen embryos for infertility in PCOS women. And we know that freeze-all is definitely better in women with PCOS. So this is from a very large Chinese data from Professor Chen Jiang's group. And it's very clear that in women with PCOS, very high responders, they definitely do much better in a freeze-all cycle. And in terms of the outcomes itself, so if you put it about primary outcome with live birth, again, they confirm live birth rate. You can see that that's very significantly different, okay? And singleton and twins as well. In terms of twins, not much difference, but live birth rates in singletons is also remains very high, significantly different, okay? And you also see that the weight is significant. Again, in fresh embryo transfer, it's still noted that, the birth weight is slightly lower than frozen embryo transfer. 200 grams different, okay, but it's still statistically significant as well. And to notice about the pregnancy loss, okay, this is something interesting that I noticed here. You probably had a higher pregnancy loss amongst women who have fresh embryo transfer in those with PCOS. Okay, and this is very highly significant. And those with among clinical pregnancies, which identified the losses, is also much higher in fresh embryo transfer. And this is interesting. I don't know how but they noticed that second trimester loss was also slightly higher, significantly higher in this group itself. So something is happening, but we know that for this particular group of women, very high responders, and potentially many of them have metabolic, risk factors as well. Okay, they will do better and they should have freeze-all cycle. And another summary table as well, which also shown that actually with the PCOS and the hyperresponder, again, this patient do better with freeze-all compared to those with non-PCOS and normal responder. The life birth rate is actually quite different. And note that again, freeze-all is not better. Okay, they can only show not better in ovulatory women. So again, from the same group, they managed to publish in NEJM again because of the large numbers they have. So they're segregated out now women without PCOS and women who are ovulatory. And what they notice is that freeze-all strategy is not so ideal again in this cohort. So again, they look at the primary outcome is live birth, and you could see that the fresh versus the frozen, there's no obvious difference. Everything is quite similar. And interestingly, amongst these women, the pregnancy loss is also not significant, except for the second trimester loss. So perhaps it's unique for this population only. Right. I think the most important thing that we want to know is that is freeze-all a really cost-effective strategy, right? Because in some centers, some women are not able to afford a free cycle. They want to do just IVF, get the embryos, put it back, and then try their best. Okay. Now, so this study is interesting, looking at cost effectiveness analysis of freeze only or a fresh embryo transfer in IVF for non-PCOS women. So we do know that PCOS women, we need to freeze-all, high responder, noted. How about in women who are non-PCOS? How cost effective we do a freeze-all only strategy? Okay, and of course, you know that the direct medical cost is actually much higher, and that's statistically significantly because everything else, what is most important is the luteal drug support, the embryo freezing and thawing, all this are money. So this is additional cost that's coming up. Okay, and how about the indirect cost itself? Probably not much. Okay, so again, longer time to pregnancy, more money directly to the patient. Okay. And I think at the end of the day, what we're trying to say is that a freeze-all strategy is very important, but there are some conditions to it. And currently, the data that we have, do suggest that freeze-all should be individualized. And of course, in certain gynecological indications whereby there is an obvious endometrial polyp during ovarian stimulation, or there's a clinically significant hydrosalpinx that you don't want to reduce the mutation rate, you will do a freeze-all for this patient. So that's clear. However, in women who does not have all these problems and are normal responders, or even poor responders, we need to be cautious and individualize how we're going to do the embryo transfer. And I think in this study itself, they're just trying to say that the implementation of the freeze-all strategy should be individualized. And the freeze-all strategy also with improved cumulative birth rates in normal and hyper responders, but not in suboptimal and poor responders. So in this case itself, I think the normal responders they're looking at are also having more eggs as well. So this is a 10 to 15 number of eggs there. And notice that for those, and the green bar is all the freeze-all cycles. It looks like it's slightly better. Well, the current normal responders, our these are good responders as well, just slightly higher. But for the poor responders and suboptimal responders, again, they probably should have a fresh transfer. Right, so answering this, I have a few conclusions from the studies that we put out and discussed together. That live birth rates, there's probably no difference in normal responders and could be worse in poor responders. You need to take note of the pregnancy complications, whether it's a fresh embryo transfer versus a frozen embryo transfer, and to discuss our patients about that. Care should still be individualized, and it must still be cost effective. Not every woman can afford multiple, frozen embryo transfers. Again, the increase in time to pregnancy from ovarian stimulation is definitely increased in a freeze-all strategy. So with that, I will just end here, and we could have a further discussion with everybody in the audience to discuss on this topic, which is still under a lot of more debate at this point in time. Thank you very much.